A very good afternoon to one and all. Welcome to today's session on recurrent implantation failure. And to speak on the topic, we would like to welcome Dr. Shivali Tripathi, our in-house consultant for gynecology and a IVF specialist. She has done her MBBS and MS. We welcome you, doctor. You can now take over the session.
Thank you so much. Hello, everyone. This is Dr. Shivali Tripathi from Apollo Fertility, Varanasi. I am a senior consultant IVF specialist at Varanasi. Today, we are going to discuss about a very important topic, which is recurrent implantation failure. For a couple who is struggling with infertility, the IVF is almost last option in treatment. So, if a IVF cycle fails, it is really frustrating and devastating for the couple as well as for the clinician also. So, today we will understand what is implantation, what is recurrent implantation failure, what are treatment strategies that we have in our basket to offer, and how to proceed such cases. So, first we will understand what is implantation. Before advent of IVF, it was not known that embryo formation and embryo implantation are two different processes. For a successful viable pregnancy, the both processes are needed to be in synchrony. If either of them is at fault, then the implantation might suffer. So every menstrual cycle aims towards the it is a steroid dependent phenomenon, and it aims towards a fertile and receptive endometrium so that an embryo can implant there. So, what is recurrent implantation failure? Till now, there is no universally accepted definition. There are few definitions which I will quote here, which we use in our clinical practice to identify such patients. Earlier, it was considered that if more than 8 embryos of 8 or more cells are transferred in a couple and there is no pregnancy, then such patients fall under the category of recurrent implantation failure. Then the definition came that if five good qualities embryos are transferred in three fresh or frozen cycles in a female who is less than 40 years in age. So if it hasn't resulted into pregnancy, then these couple also fall in category of RIF. Nowadays, the definition which is most accepted is if we have transferred four good quality of embryos in three or more cycles, and if it has not resulted into a successful pregnancy, then the patient is designated as RIF or recurrent implantation failure. And if a patient is transferred two euploid embryos, two genetically normal embryos, and still there is no pregnancy, then also the patient is called as a patient of recurrent implantation failure. So these are the definitions which are used to classify such patient. Now we need to understand what are the factors which affect implantation. So as we know, to for any seed to implant in a soil, there should be a good seed, there should be a good soil, and also the environment in which this process of implantation is taking place needs to be healthy. Similar happens in case of humans also. If there is a good embryo and there is a good fertile endometrium and the environment is healthy, and then implantation happens easily. So if any of these factors are at fault, like if there is any problem with the embryo, or if there is any problem with the uterus or its cavity, or if there is any problem in the environment, in the tubes or in the surrounding areas, then also there is difficulty in implantation. And the fourth category of patient falls in unexplained recurrent implantation failure category, in which the cause cannot be identified why the failure is taking again and again. So we will see these categories one by one. What can happen with embryo? Embryo which is not able to reach to the blastocyst stage, that embryo is not considered good, or embryo whose growth dynamics is not good, like the every stage development is not up to the mark, or a embryo which is having a thick or hardened zona which is not able to hatch by itself, or embryo which is not genetically normal. So all these embryos are not good quality embryos, and these embryos more often fail to implant. If we talk of uterine factor for recurrent implantation failure, so disease which can hamper the uterine wall like uterine fibroid or adenomyosis, or uterine septum, or a condition which can affect the endometrium like adhesions, endometrial polyp, very thin atrophic endometrium, or surgically damaged endometrium, and also a very thick endometrium. So these are the conditions which can lead to recurrent implantation failure. And now, what are the conditions which can happen in environment which leads to these failures? A patient who is suffering from endometriosis, a patient who is having toxic fluid in her tubes like hydrosalpinge, bilateral hydrosalpinges, or a patient who is having um, uh, 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 clotting disorders, thrombophilia, or a patient who is having hyperactive immunity, immune rejection of the embryo, or a couple in whom the parental karyotype is like they are having translocation, they are having deletions in their genetic makeup, or implantation is also lower, seen less in stimulated cycles. So these are the causes in which the implantation failure can happen. Now we will understand how can we address these problems. What are the treatment options are available for such patients. If we talk of embryo quality, so there are nowadays the conditions have evolved a lot. Culture conditions have evolved. Good growing good blastocyst is possible. So if we have like embryos who are having development up to blastocyst stage, each blastomere is of equal size, there is less fragmentation, and also the cell stage is corresponding to the embryo age. Such embryos are considered good embryos. Why blastocyst stage is important? Because the blastocysts are considered to have highest implantation potential. Uh, the embryos which are not hatching by itself, in them we can offer assisted hatching through laser shots, and uh, patients in whom we have found abnormal aneuploid embryos, in those patients we can offer PGTA, that is pre-genetic testing for aneuploidy. So by these methods we can get a good embryo, we can select a good embryo for implantation. Uterine factors can also be addressed. A patient who is having multiple fibroid. Now, how fibroid interferes with implantation? Since fibroid and adenomyosis leads to altered vascularity of implantation bed, so if a lady is suffering from multiple fibroid, then it can be addressed medically as well as surgically. If there are the fibroids which are obstructing the cavity, like submucous fibroid or intramural fibroid which are protruding towards more than 50% of their mass is protruding towards the cavity, these fibroids can be addressed hysteroscopically. Or a big fibroid intramural which can be addressed to both hysteroscopically and laparoscopically. Also adenomyosis, there are we are using GnRH agonist for generalized adenomyosis. 3 to 6 month therapy is given. For focal adenomyoma we can do the adenomyomectomy. Also for uterine septum, hysteroscopic correction can be done. For endometrial polyp also hysteroscopic polypectomy can be done. For the ladies who are having Asherman syndrome, who are having synechia in their uterus, in their uterine cavity, that can be corrected through hysteroscopy. For a patient who is having thin endometrium, what options are there? Thin endometrium doesn't offer good implantation bed for the embryo. So thin endometrium can be addressed through both medically and surgically. Now, what are the options for medical treatment? Any medical treatment used to treat thin endometrium have two basic mechanisms. The first is through glandular proliferation. We gives the drug that proliferate the endometrial gland, and the second thing is through increased blood supply. So, what are the options we have? we have aspirin, we have this vitamin E preparation, estradiol preparation, we have L-arginine, we have vaginal sildenafil, we have PRP, platelet-rich plasma, and GCSF preparations for addressing thin endometrium. Thin endometrium can also be improved through surgical correction. The tissuolysis can be done in patients who are having synechia, and also endometrial scratch is proven to have a good role in such patients. A patient who is having thick endometrium, what is the option? There are agents like progesterone agents, which are given for a month, for a period of 3 to 6 months in such patients to normalize the endometrium. And once the endometrium is normalized, then we can plan transfer in such patients. Now, if we talk of environmental factors for RIF, so, in patients in whom hydrosalpinges are the cause, we can do either the clipping of the tube, or we can do salpingectomy also. So, these options are offered in patients who are having gross hydrosalpinges. For minor cases in whom the hydrosalpinges are less than 10 millimeters, we can treat such patient through conservative treatment also. In cases of endometriosis, if it is severe, it can be resected surgically followed by GnRH therapy, or else we can do direct GnRH therapy for 3 to 6 months and can plan the transfer. And it has shown definite improvement in pregnancy rates. For the patient who are having immune, like, we can understand that the fetus is a immune, it is a foreign element for a mother, because it is having half of the genetics through the father. So there are females in whom the embryo suffers immune rejection. In such patients, immune therapy is indicated. For immune therapy, what options we have? We have IVIG, we have steroids, we have intralipids, we have lid therapy. All these options are there. Although the evidences in favor of them are less, but these are being used to desensitize the maternal immune system against the fetus. So, how does these therapy work? They just down regulate the antibody production in mother's body, and so that the fetus can implant, embryo can implant. Now, if we talk of there are patients in whom the parents have translocations and deletions in their karyotype. Such patients can take counseling before embarking on next IVF cycle. The patients who are having poor results in fresh cycle, in those patients, because of controlled ovarian stimulation, the hormonal milieu is not favorable. In such patients, we can plan for frozen embryo transfer. Also, if any of these therapies are not working, or patient is falling under category of unexplained IF, there are some options like endometrial scratch, but the options for such patients are really less, and being done in such patients. Um, I think I have covered most of it. If you are having any question, I will be very happy to answer those. Okay, I have a question. What question should I ask my doctor after my first IVF